I'm your moderator, Dr. Emily Solomons. I am a doctor of traditional Chinese medicine and a MyCan cluster lead and board member. I am zooming in from the ancestral and unceded lands of the Coast Salish peoples, also known as New Westminster. We have Dr. Farah Shroff, who is the founder and lead of Maternal and Infant Health Canada, as well as a former Takemi Fellow at Harvard University, and she's joined us from Cusco today. Our distinguished speakers are the reason we're all here. First, we have Dr. Margaret Quinlan. Dr. Quinlan is a professor of communication and the director of an interdisciplinary program, Health and Medical Humanities, at the University of North Carolina at Charlotte. She explores how communication creates, resists, and transforms knowledge about our bodies. She critiques power structures in order to empower individuals who are marginalized inside and outside of the healthcare system. Dr. Quinlan has authored approximately 40 journal articles, 17 book chapters, and co-produced documentaries in regional Emmy Award-winning series, regional Emmy Award-winning series. She earned her Ph.D. at Ohio University, her MS at Illinois State University, and her BS at Marist College. Then we also have Dr. Basinger, Erin Basinger. She is an associate professor and graduate program director in the Department of Communication Studies at the University of North Carolina at Charlotte. Her research focuses on how family members manage a variety of health stressors, including pregnancy, chronic illness, grief and loss, and mental illness in the context of their interpersonal relationships. She earned her PhD at the University of Illinois, Urbana Champaign,
yeah.
Okay. Her MA at the University of Georgia and her bachelor at Stanford University. So without further ado, I will pass this on and we can get on to our presentation, Breaking the Stigma, the Role of Communication in Challenging Anti-Fatness Messaging During Pregnancy.
All right, welcome. I'm Maggie Quinlan, and this is Erin Basinger from UNC Charlotte. We are so honored to be here and to have such a beautiful international audience. Is really very meaningful, and one of the main goals of our research is to really translate it to different audiences and to help get the message out there. And so we're really looking forward to this talk and then opening up for a discussion about, ways that we can apply some of this work to our own lives and to our various interests in health. So we've titled this presentation, Breaking the Stigma, the Role of Communication in Challenging Anti-Fatness Messaging During Pregnancy. So what we hope to do today is to understand some of the impact of weight stigma on pregnant individuals and their health outcomes, identifying some various stereotypes and biases towards fat individuals in healthcare settings, especially in relation to pregnancy or infertility or postpartum experiences. We'll also be exploring the ways in which weight stigma has impacts on maternal health outcomes. We would like to take a thank you. We would like to acknowledge our research team that this project started with conversations with Dr. Amy Delaney, who is now working in a hospital setting and no longer in academia with Erin and I, but our original conversation started with Amy. And then we'd like to thank our two amazing graduate research assistants, Margaret Rawlings and Audrey Curry, who without their support of this project and their help with authoring the various studies that came out of this, that it would not be possible. So we would like to thank our team. No story stands alone, that's for sure. So how did we get here? This is a really interesting and personal experience that both Erin and I are dear friends, and we were sharing some of our experiences with getting pregnant or trying to get pregnant. And it soon became very apparent to me how different our experiences were, not just in the ways that people spoke about our bodies, such as, friends and family, commenting on baby bumps or, talking about, what it's like to be pregnant or, sharing some of their stories. But it became very apparent on how different our care was, that Erin at the time was living outside of Clemson University in South Carolina and was told that if she gained, it was something like 17 pounds or something, that she would then have to go to a different hospital, the less the not as nice hospital in the town that she was living in because of BMI. And at that time, that and other messages that she received from her caregivers just enraged me. I was like, who would ever speak to you that way? Don't they know what you research? That, like, how is this happening? And so those conversations led to, me saying, Erin, let's do something about this. We definitely, if you're having these experiences, I imagine others are, and, let's dig into it from a communication standpoint and see what we can do to change some of this. And so that led to a project that happened to be at the time that we were about to launch it, that Erin found out that she was pregnant. And so at that time, I sort of took over the promoting the survey because I was done having children and no one would be guessing whether or not I was, trying to have another baby. So we started that study, and then at certain times we took breaks, just to be mindful of where Erin was in her pregnancy journey and how things were going. So as a result, we were able to do 3 journal articles out of our first set of data, and we've begun another project, which we can talk about later, which focuses on Black fat bodies and their memorable messages from pre-pregnancy through postpartum. And so we've been, had really good experiences in the peer review process with our research. But as I said earlier in the presentation, it's really important to Erin and I that we translate this research into different audiences. And so in the next slide, we talk about where we've been able to have some coverage. Erin was interviewed for Oprah Daily about some of her experiences. We've been on 3 podcasts. We did another webinar related to grief and loss, and that had a nice connections to our fat pregnancy research. And then we've our research has been talked about on some blogs, such as Emily Oster, who's a leading health and parenting expert. She's an economist by trade at Brown University, but shared some of the results of our study. And then Erin was also interviewed for Business Insider, and hopefully we can talk a little bit more about that interview. That Erin was also diagnosed with cancer during her pregnancy or postpartum journey, and some of the weight stigma that led to that late diagnosis. And the good news is Erin's doing very, very well now and is in remission. And but I think it's a very interesting part of our story as co-authors and as friends to share.
Thanks so much, Maggie. So we always like starting with that kind of overview of our personal story and how it turned into this professional journey for us. And so as we talked about how we wanted to approach the talk today, we want to kind of touch on some of the things we found across our 3 studies, but really focus on the weight stigma piece of it and why weight stigma is so incredibly dangerous. So we want to start just by making sure we're all kind of on the same page about what we mean when we talk about weight stigma. So we're going to spend a few minutes first talking about that, because it can be trickier to recognize than we might think at first blush. So in general, stigmas are based in stereotypes, which are just simplified conceptions of a group and its members. There are a lot of identities and conditions that are characterized by stigma. So ones that probably immediately come to mind are things like HIV, addiction to drugs or alcohol, type 2 diabetes, skin conditions. People who have conditions like these that are deeply stigmatized are feared, they're misunderstood, they're blamed for their conditions. But it's not just illnesses that are stigmatized. There are also a variety of social identities that are stigmatized. So people are devalued based on racial identity, gender identity, sexuality, socioeconomic status, religion, and many other identities. And we would actually classify fatness as a social identity. And we can talk about that later if anybody wants to get into why we classify it that way. So weight stigma devalues people socially because they are in a larger body or at a higher weight, and they experience stigma in the same ways that people with all of these other identities do. It's really important to remember when we talk about stigma that stigmas are not inherent to a person. They are socially constructed. So we socialize people in terms of how to recognize stigma, but also how to treat people who are stigmatized. And because Maggie and I are communication scholars, we say and believe that those stigmas are constructed through our communication with people. One of the frameworks that we relied on in this research was Rachel Smith, who's a well-known communication scholar, her ideas about what stigma messages do. So you can see that on the second part of this slide. And I want to talk a little bit about those and what they look like in the context of weight stigma. So the first and second of these go together. Stigma distinguishes people from what we consider to be the norm by labeling them as different. Socially, we have a lot of tools that do this for people at different weights. The BMI is the most common one, particularly in medical settings, but also in research, because it quite literally prescribes labels for people based on their bodies. And then because of those labels, people are separated into groups: underweight, normal weight, overweight, obese. We make a point in all of our work and in our presentation today to avoid that language because it is what's called weight normative. So weight normative language says there is a correct weight for you based on your height. So you are underweight based on your height. You are normal weight based on your height, etc. We come from a weight inclusive approach, which says there is no correct weight for anybody. There's no correct body shape or size. And so we use descriptive language. So you'll hear us saying fat, larger bodied, people at higher weights, any of that that doesn't imply that there is a correct way to be in your body. So I want to emphasize that up front, that language is really important to us. And we would say, even based on that language categorization of under, normal, over, obese, we're creating and recreating stigma. Stigma also implies responsibility or blame, and it can be very difficult. We run into this a lot to get people on board with the idea that people are not at fault for the way that their bodies look. That idea that our bodies are within our individual control runs very deep in our cultural consciousness. But it is not hard for us to believe that height diversity is natural, or hair color diversity, or eye color, or skin color. And so we would encourage you to think about weight diversity as just a natural part of the human experience. But we can also talk about the science behind that later if you want to. And then finally, stigma also links people to danger. So inherent in the idea of stigma is the idea of shame and disgrace. We see the actions of people in a stigmatized group as threatening. Stigma always elicits strong emotions, usually fear and disgust, and those emotions lead us to separate ourselves from a stigmatized group. A common example, so when I'm teaching about stigma to my students, I ask them about this, and leper colonies are the first thing that almost always come up when we talk about something like this. So that was a literal physical separation of a stigmatized group or condition. But we do this all the time with fatness as well. So we separate ourselves emotionally, physically, and we'll talk when we're talking more specifically about our study about how what the implications are of this one, particularly for people in fat bodies. People in large bodies face constant discrimination in healthcare settings. Maggie always talks about, when we give these talks, how shocked she was at some of the things that doctors had said to me. If I say those things to another fat person, they are not shocked, because this is so incredibly common. And these conversations are particularly well documented in the reproductive healthcare setting, the discrimination and stigma that shows up for fat folks. So regardless of any bioindicators of health, providers frequently categorize fat pregnancy as high risk, and that comes with a whole cascade of implications, as we know. So people labeled as high risk might give birth on separate wards, especially in non-private settings. They might be subjected to extra monitoring. They lack continuity of care when they're passed around to different doctors, or they are denied access to midwives or doulas or birthing coaches. We often see people who are denied the possibility of an unmedicated birth based on their body size. And it's very common for people to be denied fertility care if they are in a larger body. Or people are forced to diet before, during, and after pregnancy, which is not something we would ever recommend to a thin person. So we saw, both in my experiences and in the literature, that this idea was showing up over and over and over. And we wanted to get at some of the communication pieces around this. So what are the conversations that are happening when people are treated this way, when they're trying to conceive, when they're pregnant, during labor, and then postpartum? And so overall, our set of studies was guided by this big research question of what are the messages, the memorable messages that people recall across the pregnancy trajectory. And so I want to talk about the idea of memorable messages for a moment, because that term comes from a communication theory called the theory of memorable messages. And essentially it says that there are messages that stick with us in the long term. So I could ask you right now to think back to your childhood and think of a message that somebody said to you that has stuck with you. You still remember it to this day, whether it was a parent or a teacher, a friend, a babysitter, a mentor, a religious figure. We can all come up with these things. And that's because these messages are what the theorists called sticky. They're sticky messages. They just stick in our brains. And they're not always negative messages. A lot of times they're positive. They tell us something really good about who we are, what we're good at. And so we wanted to know, what are these sticky messages for people across the pregnancy trajectory? And we wanted to know three things in particular about these messages, which was the valence, are they positive or negative, the source, who is saying these things, and then the content, like what is actually being said to people. So we recruited people to take a survey, and just as sort of a side note, we thought these data were going to be really hard to get. And so we were aiming for like 50, 75 people. And within 2 weeks, we had 250 participants. So people are hungry to tell these stories. So our participants were mostly women who identified as straight and married. You can see some other demographics here, including their current average weight and their number of living children. I think it's notable, even though this wasn't the focus of our study, that about 1 in 4 had an infertility diagnosis, and this is about the same as what we see in the general population. And so there's this belief that fat people struggle with fertility more than the general population, but even just this kind of demographic piece of information is a hard piece of data to combat some of that. And so we were actually really pleased to see that particular statistic. So I'm going to talk about valence and source of the messages and then pass it back over to Maggie to start talking about the content. So what I want to point out here is that we looked at messages across the 4 what we called kind of phases of pregnancy. So pre-pregnancy, pregnancy, during labor and delivery, and then postpartum. And so some people, these experiences weren't relevant to all of them. So we didn't have necessarily an equal number of messages in each of these, but we looked at a total of 531 messages. They were overwhelmingly negative. So the only place where we didn't see more negative than positive messages was during labor and delivery, which, you know, people always ask us to speculate on why. And we always just kind of say, like, when somebody is actively getting a child out of their body is not the time to shit on them for their weight. But still, there were as many negative messages as positive. So low bar there. What I want to point out here when you see the number of negative messages is that this is not common in memorable messages research. We don't often see more negative than positive messages. And we didn't specifically ask for negative messages. We just said, what messages did you receive about your body? And so it's very telling to us that there were very few neutral messages, and that it was about 77% were negative. So this is a very striking finding, just the valence of these messages. And then our second question was about message source. So who is conveying these messages? More than half of the messages people talked about came from healthcare providers. This is not very surprising given memorable messages research, which says often these messages come from people with authority. And so it makes a lot of sense to us that that's who was conveying a lot of the messages. But we also saw romantic partners, family members, friends, and then others, which included strangers, coworkers, former partners. So a lot of people fell into that other category. And then the real meat of the study for us is the content of these messages. So what is it that people were saying? So Maggie's going to give you an overview there and talk about the first couple of types of messages, and then I'll finish up on them.
All right, so the themes that came up were categorized into these 4 categories. So thinking about the different memorable messages people received, and the first being that fat mothers are bad mothers because large bodies are not suited for pregnancy, birth, or parenthood. The second one, where participants indicated or described that they were blamed, that their bodies were blamed for the lack of competent care from healthcare providers, either because of structural barriers, absence of compassion, or lack of education on treating larger bodies. And then the third one, weight normative, was that a lot of assumptions were made or comments were made on bodies that were rooted in weight normativity, meaning that there were messages about weight or about weight loss as an indicator of health or of well-being. And then finally, the weight inclusive counter narratives, where we did see some positive messages where individuals described them as being weight inclusive or empowering and supportive. And those, we'll talk more about those in a second. So the first messages that we'll go into are the fat mothers are bad mothers. And again, the message that, because an individual is in a larger body, that they're not suited for parenthood or birth or for pregnancy. And, before pregnancy, many individuals were told that they would struggle to become pregnant because of their weight, that if they did become pregnant, that they were, told explicitly that they should gain very little weight, if any weight at all, during pregnancy, which is, very different from thin people who become pregnant, who are, advised to gain weight, such as you're eating for two, the messages that we commonly hear as people in thin bodies, like myself. And so these messages conveyed that the participants would be bad parents because of their body size. So the second theme that came up was the denial of competent treatment. And again, participants described messages that blamed their bodies for the lack of competent care from healthcare providers, either because of structural barriers, absence of compassion, or lack of education on treating larger bodies. So the structural barriers that came up was the inability or refusal to offer treatment, like when providers didn't have equipment or medical tools that would fit larger bodies, that people were denied fertility treatment because of their weight, that a lot of fertility clinics are very particular about the BMI that they'll allow in their clinics, because of, fear of the statistics for their clinic in terms of success rates. And then finally, providers demonstrating a lack of compassion and training. One extreme case ended up in a child or baby death because the provider didn't use proper monitoring devices for that birth. So the weight normative commentary on the next slide, that we saw that across the trajectory of trying to conceive, pregnancy, labor, and postpartum, patients were inundated with comments and assumptions about their bodies rooted in weight normativity. At the basic level, such commentary showed up in remarks about participants not looking pregnant because they were fat, or still looking pregnant after birth. Many participants were encouraged to breastfeed, not because of any benefits to the child or to the mother, but because it would help the mother lose weight. Participants also described a range of assumptions that people made about their bodies and health status based on their size. Providers assumed that patients had high blood pressure or gestational diabetes, even if there were no biological markers for those diagnoses. Many were warned that they would need more monitoring or testing during pregnancy, interventions during labor, or often threatened with a C-section. And again, those comments reinforced ideologies that fat bodies are not suited for pregnancy and birth. And then to end, that, we heard so many negative comments. However, there were some counter narratives present. These comments were more weight inclusive, empowering, and supportive. Partners and reproductive providers like midwives, doulas, and birthing coaches were frequently cited as sources of encouragement in this category. Participants found often that the absence of talk about their bodies was helpful. So a provider not mentioning a person's weight was seen as being positive, that fat people are used to their bodies being the subject of discussions with providers. So it was pleasantly surprising, in quotes, when their weight was not mentioned. So, to kind of conclude, the weight inclusive counter narratives described fat bodies as beautiful, strong, and able, disrupting narratives that appraised fatness as unhealthy, lazy, and immoral.
So these messages are really striking on their own. And when people see those example quotes, they're often pretty shocked. And so it's important to us to get those messages out there, but just as important for us to talk about the implications of the messages, like what is really at stake here for fat folks across the pregnancy trajectory. So across all of those messages, we saw a lot of stigma. We saw the presence of or promotion of fear and disgust about the fat body. And those messages that we observed had all of the characteristics from the stigma framework that I talked about a little bit earlier. And stigma is very damaging in its own right. We know that there's a host of negative outcomes that come with being stigmatized. But for us, the most kind of damning one is the idea that stigma threatens the community. And if we want to challenge stigma, we have to stop the threat, or challenge the stigmatized group. We have to stop a threat. So in this case, we saw that through the denial, particularly of fertility care. And so there was a real agenda, we would argue, that because there's this sort of fear and disgust of bad mothers, and we use the word mother intentionally, but bad mothers, fat mothers, that this pretty quickly devolves into an agenda that's very similar to eugenics, that we control the population by determining who is quote unquote fit to be a parent. And in this case, fat folks are not deemed fit, and so their reproduction is controlled by people with power who say that they shouldn't be parents. There has been some writing about this in the past, so we're not the first people to find this in our data or to talk about this idea. And I think it really needs mentioning over and over and over that what's at stake here is, first, life or death for fat people themselves, because it's not uncommon that really negative things happen or fat folks die because of the way that they're treated. My own experience is not, sort of the main thing we're talking about here, but my cancer diagnosis was missed for months and months and months and maybe years because doctors kept writing it off as just fat. And so, this is a big thing. It's not about hurt feelings. It's about lives being lost and saved. We also talk about in some of our work that medical professionals, just in general, are showing us through these data that they don't know how to treat patients in larger bodies. And there's no excuse for that, but there is a pretty easy explanation. A 2020 study found that only 10% of medical schools felt that their students were prepared to treat people in a variety of body sizes. And a third of those schools said, we have literally no education about this. Half of the schools said expanding that education is not a priority for them. And the education that is present is pretty rife with stigma. And so it's pretty easy to understand why this happens, not excusing it, but we know people aren't trained to do this well. But we also know in a more promising way that even short trainings make a really big difference. And so we proposed some options for what a training in this area could look like, but we see that as being a really promising avenue for starting to address this problem at a more structural level. We also support the argument that other people have made that research on fatness is incredibly flawed, because for the most part, it's based on the BMI, or it's based on other kind of flawed ideas about fatness and health, and those two things being one and the same, when we know that that's not true, that there's no kind of nuance to that argument. And so we always promote, when we're talking to a group of researchers, that we need to sort of rethink the assumptions we're making when we're doing work about bodies and pregnancy and health. And then we also note that a lot of structural and policy changes are implicated because people in our study were denied medical care, and in the US, there's no repercussion, discrimination against fat people is legal in the US, and that's true in other countries as well. Hopefully many of you fare worse than this, fare better than this. And we say that that is at best unethical. at worst, it is threatening people's lives. And so we see a lot of changes that need to happen for there to be an infrastructure to support fat people in this context. So where do we go from here? We want to talk very, very quickly about some advice, because that's a question we get all the time. It's like, okay, well, what do we do? Like, you just told us that the system is broken and fat people are being harmed from every direction. So what happens now? And so we have compiled some advice for professionals and then also some advice for fat folks. And so we want to just not kind of spend too much time on this, but we do like to end on this note that, like, there are things that all of us can do to make this better at the individual level while advocating for more structural change. So Maggie will talk through the advice for professionals, and then I'll talk through the rest of the advice.
So our first suggestion is to use inclusive language. We understand that overweight and obese are clinical terms, but this is a relatively new decision. Before the 1970s, this wasn't a major discussion. And in fact, in the late 1970s, the Health Financing Administration explicitly said that obesity was not a disease. It wasn't until 1998 that the NIH classified obesity as a disease. In 2013, the AMA made these clinical terms, and the goal was actually to reduce stigma, but the decision did just the opposite. The Obesity Action Coalition has actually found increasing social discomfort with obesity since these decisions. Regardless, these words have been weaponized against your patients for years, and they're a real source of shame. Our advice is to take cues about language from your patients. What language are they using to describe their bodies? And then to use those terms that they use. Avoid talking about weight if it isn't relevant to the conversation. And when you do talk about weight, don't label it if you don't need to. We've always said that, descriptive language, like Erin has been talking about, is far less loaded than normative language, so try to use descriptive words when possible. And then our second advice for professionals is to create accessible physical spaces for people in your environment. Discrimination is subtle in this way, but having chairs without arms, cuffs, gowns, beds that fit a wide range of body sizes makes a huge difference for your patients. Think about having a step stool, then, towards next to hospital beds, so that it might be hard, for people to get on to the beds. Double checking if your machines fit people with larger bodies. If not, to have an alternative way to get patients the care that they deserve. These may seem like small changes to some people, but they can make a big difference in terms of the accessibility and inclusivity of your environments. So our third piece of advice is that it's important for you to be armed with knowledge of where your fat patients have been. Erin has been interviewed by a few media outlets about her experiences as a fat person and has been met with shock at what people have said to her. But when we tell other fat people about these experiences, they aren't shocked at all, because this is a common experience for fat individuals. Your patients may be on the defensive when it comes to you, because the literature tells us that a majority of them have been treated poorly because of their weight. And this is why it's so important that you have compassionate care and offer evidence-based care to your patients. And, it's important that participants, that if it's not relevant to what a patient is going through, to not mention their weight. And you don't have to say anything positive. You can just refrain from saying anything negative. And finally, we encourage you to be willing to look twice at your assumptions about weight. Medical professionals have made horrifying mistakes based on false beliefs about stigmatized social identities, especially race. These have led providers to do barbaric procedures on Black patients. For example, not believing that they feel pain has led to eugenic practices such as forced sterilization of Black and Native American women in the US based on the idea of biological inferiority. These types of decisions seem outdated today, but they have had lingering connections to even today's medical practices. What we are proposing is that if we've been so wrong about other social identities and their relationships to health in the past, we'd like for you to consider that we may be wrong about weight too. And so, we acknowledge, right, that when our students ask, are weight and health correlated? Sure, but in day one of any of our research classes, we talk about the difference between correlation and causation and how they are not the same. There may be many intervening variables that are likely to explain the relationship between weight and health, but weight stigma is a major one, and scientific research has identified others, such as weight cycling, avoidance of healthcare, poor access to preventative medicine, and others, which are impacting individuals' care.
And then we want to end on a note about some advice for fat folks who are navigating this system. And this advice is based on some of the data that we collected, that we asked people, what would you say to somebody else who's going through this process? And I don't know if we have any fat folks on right now. Maybe they'll find this recording, but we do think it's really important to say, this is not on you. The system is broken. You are not broken, but there are things, if you need them, to be armed with to kind of help make this process less challenging. And so we divided this advice into three kind of big sections. So we have intrapersonal advice, which is self-focused, communication advice, and then support advice. So the number one piece of advice that we saw over and over in the data was to trust yourself and trust your body. And that can be a very big ask for people who have been told their entire lives not to trust their body, that their body is wrong. So this piece of advice, I think, really touched me as a person, because you can trust that your body knows what to do and that you have intuition that is able to be trusted about the pregnancy process, despite some of the discourses around fatness. Another piece of advice was to focus on health, not weight. We know that it's ultimately behavior that is correlated with health outcomes, sort of traditional metrics of health. So is exercise good for us? Yes, of course. But that's true for people in any body size, not just for fat folks. And so focusing on having a nutrient-dense diet, on nourishing your body, on getting out and joyfully moving your body, like these are things that we should all do without focusing on how it affects our weight. And then do your own research, which is a pretty loaded idea culturally right now. But ultimately, this advice was saying, the first thing your doctor says to you that's really stigmatizing may not actually be true. So be willing to look into it a little bit more. We also saw two pieces of communication advice. And this first one is a little bit heartbreaking because it said, it is inevitable that you will get negative feedback during your pregnancy or during your attempts to conceive. And it's important to kind of develop a thick skin and just to be armed for that conversation, because poor treatment, hurtful comments, like those things are going to happen. And so preparing yourself, steeling yourself for it can help you not to feel caught off guard when it does happen. And they also talked about the importance of advocating for yourself, speak up during a doctor's appointment, ask for what you need, pursue competent and compassionate care. So they were really adamant that people deserve to be treated well. And that's, that should be our standard, right? When we're talking with folks, is that they deserve compassion and competence in their care. And so people were really encouraging the idea of self-advocacy. And then our participants also emphasized the importance of social support. And so they talked about, if you can, find an inclusive provider. I will say those are incredibly difficult to find. Maggie and I live in a really big city in the US, and it is hard even here to find inclusive providers. So this is not an option for most people, but when it is, it's great to pursue. They also talked about seeking support from close and trusted others. So not everyone in your network is going to be affirming, but really find and capitalize on the relationships that are. And then people also talked about finding online communities, because there are really great supportive spaces for fat folks online. And people named a few specific ones like Plus Size Birth or Plus Mommy, and we've come across several others in our work that are really fantastic. But they said, you know, even if you can't find an inclusive provider, even if your family and friends are saying unkind things to you, there are places where you can get the support and affirmation that you deserve, and you might need to go online to find those. We will end there. I put our email addresses up here, and Maggie and I are happy to talk more. I also will stop sharing my screen so that we can have a discussion, and we really welcome your questions. We always learn a lot through Q&A sessions that we have during these talks. So we're really excited to hear more from you and talk about the future of this work.
I really enjoyed this this presentation. I really want to say, like, this conversation is so long overdue, and on behalf of Maternal Infant Health Canada and the Obstetrical Acupuncture Association, we really appreciate not only you doing this research, but also speaking up on the injustices and helping those of us personally working with all bodies in pregnancy, but also speaking directly to people with larger bodies. It can be so isolating, and so I really appreciate that you added both, you know, a direct message to the people themselves, and then also all of us who need reminders, even those of us who, you know, believe that we are open-minded, to be able to hear these things over and over again, getting gentle, firm reminders that what we say matters all the time, every single appointment, and what we're focusing on matters. And sometimes silence is better than speaking about that, and focusing on really the true health pieces, as opposed to what their bodies look like. We are, as we're kind of getting some questions coming in, the first one I wanted to ask is, I really appreciate that you talked about the fertility piece as well, because that is something that I know personally I see a lot in clinic with my fertility practice. And one of the things, if you are helping your patients advocate, if you are navigating the IVF and assisted reproductive technologies world, as well as in pregnancy, when we're talking about surgical interventions, one of the things that's always kind of the shutdown is talking about, oh, your BMI or your weight is too much for anesthesia, so we absolutely can't do you any kind of, we can't support you because until you get underneath this BMI or underneath this weight. And so when using that, it's really hard to advocate around it. So do you have any suggestions for when people are, you know, met with that specific kind of counterpoint or block?
Yeah, so I often tell people to keep digging when that's the advice that they get, or that's the statement that they get. I can only speak to the way the systems work in the US, but often that's something mandated by insurance. And so coming up with an alternate either payment structure or finding something that is more medically necessary, because my BMI is above all of those points. And when I had cancer, I was put under anesthesia many times and it was fine. So there's not actually a problem with anesthesia for fat folks. It's just when people are willing to assume the risk. There are also some studies about anesthesia for fat people that don't come from this kind of weight normative approach. And so I think presenting some of that evidence can be helpful. This is also where we need structural change, though. Like, ultimately, insurance companies get to dictate a lot of the care that fat folks get. I still have a bunch of like leftover stuff from when I had cancer that no doctor will remove. I'm like, well, you didn't have a problem doing any of my surgeries during cancer, but now we won't take it out. So, you know, it's just like there's a pretty unfair game being played, and fat people are the pawns in this game. I definitely think it's important for providers to do the advocating. So writing letters to insurance companies, calling insurance companies on their behalf, and it's more labor for you, but particularly if you're a thin provider, you have more credibility with the insurance company. And this is also one of the things that Maggie and I have seen is that I'm the one with the lived experience, but Maggie gets deferred to all the time in these conversations because she is thin. And maybe also Maggie because you're fully promoted. I don't know, and she won an Emmy, so I can't compete with that. Maggie, I don't know if you have other advice. Maggie's expertise is really in infertility care, and so she knows a lot about this area.
I think the one thing, about this research is I've had to rethink so many things and, realize how entrenched I was in some of this thinking and the ways it's impacted my health and, other things like that. But the one really big aha moment for me was we were talking with a fat activist about our research, and she was saying how in infertility, they don't change the dosage based on body size. And so that's why, percentages of treatments don't go well. And it just sort of like blew my mind. And I hate when I do this, but I'm always like, we wouldn't do that for cancer. We wouldn't not change a dosage that would work for that person's body due to size, So I just think how archaic some of these practices are, and like why we still do a lot of these things. And again, there's been, even doing this research, just even becoming more comfortable with the word fat, which, has such a latent term, and, sort of reclaiming it in our research has been, I've had a lot of big growth moments as somebody who is a thin ally.
I put Nicola is the advocate that we're talking about, Nicola Salmon, and she is based in the UK. She's incredible. And she wrote a book called Fat and Fertile that addresses a lot of this stuff. She has resources on her website. Her book is amazing. And she's somebody who does a really nice job of breaking down research into very palatable kind of descriptions that people can share with providers and insurance companies and things like that. So she's a great resource.
Oh, thank you. Definitely looking into that. On this same topic, Gary Adams has a question. He said, "Thank you for your webinar. I wonder if it is if different clinical units have a varying approach to the use of the word fat, which creates challenges. Yeah,
I'm happy to talk about this because I get a lot of pushback on this idea of using the word fat. One time I was giving a talk about type 2 diabetes and weight stigma, which is the other area of research that I do. And a doctor said, well, I just don't think it's good to call patients fat or porky or lard-ass. And I was like, respectfully, I don't think those things are the same. So I do think that fat can be a very loaded word. And I use that word to describe myself. But a lot of people are not comfortable with the word fat, and that's fine. That's where I think it's important to talk about, like, somebody's weight is a number that you have. Like, you can talk about a particular number, or you can talk about being in a larger body, or just don't say it. I mean, that's fine too. If it's not important to say it, don't say it. But often people will use a word for themselves, like, I know I'm bigger, or whatever. If that's the word they're comfortable with, then just mimic that. So you may not be the one to start with the word fat, because some people hear that as an insult rather than as a descriptive term. It isn't for me, and in fat activist spaces, it's not, but like, that's not the whole world. And the word fat has been weaponized for many years, and so totally understandable. I would say use softer language than that maybe to start with.
Yeah, that was crossing my mind too. I said, oh, I don't know if I'm quite ready for that. Like from advocacy groups, I know it's like reclaiming and claiming the word, but I feel like I would never jump in with a patient and say it unless they describe themselves in a positive way like that, and then or even ask, is that how you would like to describe it? Something along that kind of
totally fair
realm.
Maggie, maybe you can talk about that from your perspective, because it took Maggie some time to get on board with using the word fat when she and I started doing this work together. I think that was less comfortable for her.
Yeah, I mean, I definitely had to sit with the discomfort, but now, I mean, just the word obesity just like tenses up my whole body, you know, now that we've done this research for a while, and just where that word came from and all of that has, you know, unpacking that has been really, really important to this work for me.
Sharon Musa had just some comments that she wanted to share. She said, so many touch points to mention: early pregnancy, oops, sorry, somebody else just, there we go. Early pregnancy and hearing heartbeat. People are told that because they are fat, a heartbeat may not be heard, and so they have a longer period of worry that the pregnancy is viable. The fat vagina tag, that there's so much extra tissue in the vagina, the baby will not be able to fit. Fat people only grow large babies. Not having birthing equipment in the labor and delivery rooms that fit larger bodies, birth balls, tubs, etc. So I could go on and on and on. Very true.
Same. I could also go on and on and on.
Corey McGrath wrote, we find this frustrating in our hospitals also, being denied care at one hospital if a BMI is over 46 intrapartum. They literally will put folks on the scale and transfer them out in labor. They claim it's an anesthesia problem. That's the thing, right? And yet they're not turning folks on non-obstetric units away for these procedures. We've had to file a complaint against anesthesia for thanking women for staying thin and making their jobs easier. Just brutal. This is important research. Thank you for sharing and giving tools to those of us who are advocating for change. I want to say too that did bring up when we mentioned anesthesia earlier. I'd be curious. Nicola, I think who you shared was from the UK, is actually comparing countries. So I'm in Canada. You're talking about insurance. We have public health, so it's less about the insurance companies. But I think we're quite impacted by the policies in the States. So oftentimes we get, you know, the good and the bad, even though it's not technically insurance companies deciding these things. But yeah, you know, looking to see what are they doing, what are the restrictions in the UK, what are the restrictions in China, what are the restrictions in India, you know, what and yeah, and just seeing, okay, what's done and what are restrictions within different fields. I like that advice as well, really looking at like, well, surgeries are done for this case and for that case that are non-obstetric, and they can handle this the anesthesia. So really kind of pushing back, and that's given me confidence to start really asking those questions. This, I can't thank you enough. This is really a conversation that isn't happening enough, and the fact that you are taking the time to actually speak about this to all sorts of different groups. We will be sharing it. It will go on all sorts of different platforms, because I think this message needs to be heard. So I do want to thank the webinar team at Maternal and Infant Health Canada. So Tomi, Anat, the whole webinar and social media team for working and organizing, promoting this event, and to Healthy Seminars for donating their platform for us to host again. So thank you to everybody. And most importantly, thank you for everybody to join and for our speakers. So thank you so everybody.
Much. It was an honor to be here. This was
Emily,
really fun.
If all of our articles on this topic are behind paywalls, but if anybody would like a copy, please email us and we're happy to share them.
Oh, I think Barb's raised her hand. Yes. Do you want to maybe just put your emails one more time in the chat so that anybody who does want?
Yeah, I just put them in there a couple of seconds ago. So.
Oh, perfect. Oh, yes, there they are. Okay.
Yeah, we're happy to find our way around the journal policies and share these as widely as we can.
Yes, I think we need that. Thank you so much. Let's see if we
Thank you for having us. We really appreciate it.
Keep in touch.
All right. All right, everybody, take care. I hope you have a wonderful rest of your morning, noon, and evening, wherever you are. If anybody has any topics that they would like to share on Maternal Infant Health Canada, you can also reach out to us at mycancares@gmail.com. Have a wonderful rest of your day and week.
Thank you so much.
Thank you.